Good afternoon, colleagues, and a very warm welcome back after your lunch break. I hope you all had the opportunity to not only have lunch, but look at excellent posters and also had the opportunity to network and learn from each other. This afternoon's session is, we're going to start off with the presentations on clinical pathway and transformation. And I genuinely hope that you have been inspired by these morning sessions as I have been. So I'm Malti, Varshney. I'm Director of Population Health and Strategic Change in Kent and Medway ICB. And I also chair the Clinical Advisory Group for Net Zero for NHS England. By professional background, I am a consultant in public health, and it was heartening to listen to previous presenters and discussions around population health, public health. So it won't surprise you if I start off by saying the same, that climate change has a global threat to our population's health. To address this threat, we need to take action at all levels, not just what the work that our NHS colleagues, England colleagues are doing by net zero and by introducing and setting up the aspiration and ambition by 2040 to be net zero. We need to take action at a local level, at system level, regional level, neighbourhood level, which is where our PCNs and practices are. We need to be working with our collaborators, our partners, as we have heard during the morning session, with our local councils. We had excellent presentation around taking a whole well-being approach to addressing the climate threat that we are facing. This action can only be undertaken by the leaders sitting in the room and really encouraging that distributed leadership across the whole system. From public health perspective, there are numerous opportunities to consider whole patient pathway, to understand where might be the opportunities to embed sustainable practices in that specific clinical pathway. I heard this morning, in the morning session, there was a phrase that was used about reimagining healthcare. We have a real opportunity where each of the systems are looking into establishing their integrated neighbourhood teams. What opportunities are there for us to consider integrated care pathways? We had another presentation this morning talking about the low-value bloods being undertaken. Those are the examples that just really provoked a lot of thought in my own head, that how can we take the opportunities, the requirements that we as an ICB are having to do as part of our business as usual, but how can we embed sustainable practices in that BAU? That is something that I will be thinking about and mulling over the coming weeks, coming days, and I would encourage you to do the same. What we have now got is a very short video which was really thought-provoking for me, talking about the waste generated through breast reconstruction surgery. We'll be playing that video very, very shortly. And after that, I have got two excellent presentations, one looking at surgical pathways for laparoscopic cholecystectomies and what can be possibly done in an inpatient setting. And Firaz will be starting us off with that. And then we have second presentation from Lynn, who will be talking about an outpatient setting as well. After these sessions, of course, there will be an opportunity for us to go through the questions and answers. So I would now, if we could please start the video. Thank you. Thank you. This video was by Maria, who is a Dutch artist. And when I watched this video, it definitely provoked a great deal of deep thoughts in me, considering our practices. As you consider the insights that this video may have generated for you, I'd like to now invite Firaz to share his presentation. Thank you.
Thank you. Thank you all for being here, and thank you for the interest. And I really appreciate the passion we have for reducing the carbon footprint of the NHS. Right. So my name is Firaz, and I am one of the surgical registrars working in Manchester Foundation Trust. But for the past year, I've been working as the GIRF Fellow for MFT, and our aim was to optimize day case procedure pathways for... sorry about that. So I've been working on this massive quality improvement project to increase our day case rates and increase throughput. But out of both an academic interest and a personal quest of mine to reduce our carbon footprint within the NHS, I wanted to see how we can actually reduce some of our carbon footprint. And we wanted to look in particular at lab colis. So is this how I... Sorry, how do I change? There we go. So for all of those who may not be familiar with what GIRF is a national program to decrease the variance between trusts, and we learn from each other, and we basically try to improve our services. But like I said, out of an academic interest in our carbon, becoming carbon neutral, as the NHS has set up an agenda for it, which has been extensively discussed this morning, so I won't be going into detail about that. But out of, I wanted to, when I was doing the background work for this study, I wanted to look at some facts, and some of this definitely did surprise me, and it might surprise some other people in the audience if they're not aware of this. So, did you know that globally the healthcare sector emits 55% more carbon than the automotive industry? And I know we like to blame cars for most of these problems, but it might be us. And then in 2019, we know the story. In 2019, we declared a global emergency, the carbon emissions as an emergency overall for the UK, and we wanted to sort of reduce that carbon footprint as well. But one of the other things, and why this is our problem, is actually because low-income countries have a much lesser carbon footprint as compared to higher-income countries. So, and me being from a low-income country, and which was devastated by floods last year, I am personally very passionate about reducing our carbon footprint in the NHS, because it will threaten to undermine all the good work that the public sector has done overall. So, these were the targets we mentioned earlier, and I won't go into detail about that. So what did we do? We looked at retrospective data for, GIRF allowed me access to national level data, so we got all the lab colis that were done, laparoscopic cholecystectomies, which is an operation, for those who don't know, to remove the gallbladder in a patient. We looked at all those procedures done across England from in the year of 2022. And what we did was we looked at the surgeries that were done as a day case and versus those that were done as an inpatient. And because I was looking to improve our services in day case surgeries, I wanted to look at how we can improve, whether there's a difference between an inpatient stay versus a day case procedure. So we got the figure for an inpatient stay at 37.9 kilograms of carbon equivalent. This is a figure provided by the Sustainable Healthcare Coalition, and this is an average figure. So we used this as like a template to calculate the carbon impact of these surgeries. And we obviously jotted down to an ICB level for analysis, and there you go. This is what we got. So we got data for about 48,000 lab colis. About 66% of them were done as day cases, and of course there was variation in how the day case rates of these lab colis. We then went a bit further, and we saw that the upper quartile, which you can see in the green over here, of the upper quartile of the highest performing ICBs, the ones that were doing their day case rates above above a 71.8%, which is the minimum. Now pay attention, this 71.8% was the minimum day case rates of those upper quartiles. So we wanted, and those can be highlighted in, those highlighted in green. Now what we wanted to demonstrate was actually that if we did day case surgeries at the minimum level of the upper quartile in those surgeries, how much carbon could we save if we were as good as the minimum performing, highest performing upper quartile ICBs? So we found that we could actually save up to 190,000 kilograms of carbon equivalent, which is the equivalent, and when you divide it by a factor, divided by the number of the energy used to power one home, you could see that we could power up to could have powered up to 172 homes across England in the year of 2022. So this is an interesting graph which will show you that the difference. So if you look at the blue line over there, that actually is the actual carbon footprint of lab colis done across England in 2022 versus the orange line, which and the difference between them is the savings that we could have had between that time. This yellow peak that you see over there, that's actually an anomaly because that particular ICB is performing much more volume-wise as compared to the others. So, but it'd be interesting to see if they performed at even a higher rate of day case procedures than how much carbon they could save. So, in conclusion, what we to me, as a person who's been working for increase our productivity within theaters and with the kind of elective backlog that we have in the NHS, which is the problem that we face these days, it seems to me like a no-brainer that we should be working towards more day case procedures in surgery, and we should be promoting more elective day case activities within theaters, because cost saving and it will clear the elective backlog. And what do you know, it can save carbon as well. So that's what this study basically shows, and I hope that was informative for the people in the audience. Thank you very much.
Good afternoon. Thank you very much for listening to me today. So I'm going to go through an outpatient pathway, which is just slightly different to Farrell. And what I'm going to talk about is a change, a transformation. And as most of us who work in the NHS as jobbing consultants know, most transformations come out because of financial gain. And so that's what the driver is. But what I want to show you is that we all know that enough don't get developed because of environmental gain, but I want to show you what happens when you actually get the patient involved, and that's the social gain. So you can hit the triple bottom line using the social gain, i.e. the patient voice. So I just want to learn how to use the on button. Sorry. So HIV, for those of you who don't work in HIV, is a transmissible disease which is very well managed with very potent antiretroviral medication that is available to all of us here in the UK. If you want to know that that medication is working, you do what's called a viral load. So we bring patients up, we just take 3 blood samples, and that's your viral load. If that viral load is deemed to be undetectable, the patient is likely to stay well and not get sick from an HIV-related condition, but they also are unable to transmit it to other patients. And that's obviously key to public health and the control of HIV in our country. So currently, the BEVA, British HIV Association guidelines, are for 6-monthly monitoring of HIV-stable patients, and this is what we wanted to challenge and to change. And that's because those guidelines, and the clue is in the term guideline, were written quite a few years ago, and a lot has changed since then. So we have much better HIV care. We have a lot of very, very good potent drugs in single tablet combinations, which drives adherence, which drives a low viral load, and improves care. And then we had the COVID pandemic, and we learned a lot because we couldn't bring patients in every 6 months. My service, we have a big hub based in an acute hospital trust, and they closed the doors. And so for each patient that was coming up, that was due to come up, that we were meant to measure their bloods and then determine whether they needed a 6-month prescription or not, we had to look at them individually and say, is the risk of bringing this person into a COVID-stuffed hospital more than writing another prescription for 6 months without doing a blood test? So when we came out of it, we had this whole group of patients who we hadn't seen for 12 months. And obviously we're starting to see them, talk to them, make sure they were okay, and retest them. So if we want to continue this 12 monthly as opposed to 6 monthly, who do we need to convince and how do we do it? So I would tell you there's 3 things that you need to do, 3 people, 3 groups you have to convince. And the first is your senior colleagues. Now, colleagues are always concerned, quite rightly, about safety. So you look at the guidelines, you see what the level of evidence is in those guidelines for what you're doing or what you're told to do in those guidelines, and you look at how things have moved on since those guidelines were written. And as I mentioned, the drugs were better and we had the COVID experience. And then the big thing that's often the block is the staff view. So the NHS is just full of habits. You know, I learned them for where I trained, I've taken them to where I work, and I teach my juniors. And so you have to look at those habits and you see that the staff perception that patients love to come and see us every 6 months, is that actually true? And that was where I got quite a lot of kickback with, particularly around the nurses who had a fantastic relationship with these patients because they are chronic care patients. And they said, no way, they want to come and see us, they love telling us about their kids, etc., etc., etc. So that was the big block that I knew we were going to have. So what we did was I looked at what would make the patients not want to do this. So first of all, they need to feel secure. They need to know that you're going to keep them safe when you change a pathway. But also, they need to know what the safety netting arrangement is. What happens if something goes wrong on that new pathway? And I think all of you will recognize that patients really worry when they can't get through to somebody on a telephone. So we were very careful about that. So that prompted us to design this study. So we had a fantastic electronic system of communication during the pandemic, and we knew we could get information out to them electronically. It didn't need a letter. So we divided our patients into cohort A, which was very stable, and we defined that. And we agreed that would be someone who'd had a virological control for at least 2 years with no other HIV comorbidities. And the plan was to reduce their attendance from 6 months, and they would only come in every year. But at the 6 months where they weren't coming in, we would phone them and check that everything was okay. And we guesstimated that this would apply to 70% of our cohort, and at that time we had about 1,000 patients across Northamptonshire. So we asked the patients, and what we did is the first 100 patients who came in, we gave them a piece of paper, gave them lots of time, and we asked them how they came. Car, diesel, petrol, how many miles, how long it took them to get there and back. And then we asked them the financial effect of attending a hospital outpatient appointment. So, can you take sick leave? Do you have to take annual leave? Do you not get paid if you have a 0 hours contract? And alarmingly, there were almost 30% of people who fell into that category. So it was very difficult for them to come to our appointments. So we also said, the one question we said is, if we can assure your safety, would you like to only come once a year? And I'll show you the result of that in a second. And then the final question was, is the environment important to you? And we didn't want to put it at the top, because then they might say, well, I came by bicycle, when actually they came by car. So the patient voice told us that over 90% had approval for reduced attendance. And when we look back at the 10%, some of whom we knew very well, they said that they hadn't understood that we would still have a conversation at 6 months. They thought they just weren't going to have any contact with us. So remember, we did the survey before we explained to them what we were actually doing. 95% approved the electronic link, and that was really important because we have to have a way to really communicate with everybody. And HIV patients, many live in houses of multiple occupancy. They don't want letters flying around. And the average saving per patient was £9.20. That's just the travel. That's the getting to the hospital and parking. It did not include the loss of earnings, which in some cases were absolutely significant. And 84% said they were environmentally concerned. So that is the social part of the triple bottom line. That is what patients actually want. It was completely different to what staff thought. But this is the rest of the bottom line. So the environment, and you'll see I've got two figures. I've got one here and one in brackets. And so the CO2 saved was originally, on that calculation of 70%, was 108 return trips from Northampton to Glasgow per year. Now, probably nobody knows where Northampton is. It's just by Milton Keynes, so it's about an hour outside of London. That is a long way. But actually, we now know that this is going to apply to over 90% of people. We've had 3 people say no, thank you. So that probably puts that up at well over 154 return trips. The financial savings on consumables alone, so that's just your blood bottles, your needles, your swabs, etc., was £45,000, which again, if you extrapolate that to 90% of the cohort, comes up to over 64,000. And then really interestingly, and this was one of the big drivers that had sent me into looking at this project, was actually the nursing time, because there's this increasing demand on nurses, on all services with less staff. So we could save 350 hours, and again, if you extrapolate it up, 500 hours of Band 6 nursing time a year. And the one thing that I want to point out to you is that that cost of that Band 6 nursing time is not factored into that £45,000 saving. That was deliberately not included because I didn't want the trust or anyone to take it away. I wanted the nurses to not only have time to do their CPD and all the other things, but to be able to spend time with patients who were struggling with adherence. Because if you're non-adherent, your viral load goes up, you can transmit HIV.
Then I'm sorry, we'll have to move you on.
Sorry, can I just do this last slide? So just to finish, this is a project which shows the triple bottom line. So it's environmental, social, and financially beneficial with significant benefit to staff. But it was applicable to 1,000 of our patients, and there are over 100,000 patients in HIV care in the UK. And I think this is applicable to multiple other specialties. Sorry that I overran.
Great. Thank you for that. Brilliant. This was a really excellent example of how we can embed the sustainability in clinical practice for the benefit of not just looking at the pound sign, but also looking at social value and improved outcomes. And NHS is about improving outcomes and access for our patients. So I'd like to now have just a few minutes for a few questions. So are there any questions from the audience? Whilst the audience are thinking of, can I just ask a question then, please? So let me go to you first, Firaz. Could you just share with us what were the challenges that when you started to think about it, what were the challenges that you encountered and how did you overcome those?
Yeah, so with regards to this particular study, one of the major challenges that we faced, and I'm sure anyone who's studied these things has faced these challenges, is attaching a good carbon figure to what we are for a particular procedure or a particular inpatient stay. So we got our figures for this study, particularly from the work that Manraj and Joe and Maria have done in another paper, which also, by the way, should demonstrate that in increasing activity in day case TURBTs can also bring down your carbon by quite a lot. So that's one of the major challenges with studies like these, actually.
Great, thank you. Would you like to elaborate on what challenges did you encounter? I mean, you've covered quite a few.
I covered quite, yeah. I think I just want to start off by saying that this project would probably not have got off the ground without the Centre for Sustainable Healthcare. So I did this as part of the Green Project, which means you had to start and complete it within 12 weeks. And they were fantastic in helping me get all the figures, the carbon figures, etc., and giving me guidance. I think it ended up being easier than I thought because we got the patient voice in first. Mm-hmm. And where staff were like, no. When you see 90% of them going, yeah, absolutely, we want to do this, it's quite hard to argue.
Great. So not in collaboration, not just with the local partners, but be having patients helping you drive the project is a really important message that I'm hearing. Any questions? There's a question here, please.
Where am I going? Where am I going?
I must have it.
My glasses on as well.
I could quickly pass this. Let me just hand you over mine to save time.
I just wanted to, I know of a similar project to yours which reduced the number of attendances at an inflammatory bowel clinic, and it was very, very unpopular with the hospital because it reduced the income of the hospital because they got paid for visits but they didn't get paid for keeping people away. How did you get over that?
Well, I think that's such a good point because you will struggle if you're on payment by results. Now, it's quite disappointing we're not on payment by results for our service. We're on a block contract, so we get nailed in another way. But they didn't care because it wasn't going to affect our income. But actually, so there was a saving. But I think to me, the big saving was, so the response to the patients coming back now, which we'll present when we've got more data. But for the nurses, it's been absolutely significant because they were on their knees. We've had, the UK in the last 10 months has had 22,000 new HIV patients, and that's purely being driven by the recruitment overseas for social care places. So projects like this, and actually what's really relevant about this is I'm actually Zimbabwean, I've been here for years, but a lot of the patients coming in are Zimbabwean. They're completely used to not being seen for a year or 18 months, and they're very responsible about taking their drugs because they've seen people die. So actually, you do have to check with your trust. And that's why I started off by saying most transformations are financially driven. And if it's going to be negative for the trust, you're going to have a problem.
But patient activation is really crucial, is what I'm taking away as well.
Key.
That's brilliant.
I'll do one question.
Okay, great. Thank you.
Thank you. Really, really interesting. Thank you. I mean, that's a really, really important point, isn't it? Because those are perverse incentives. And we can't keep finding ways of wriggling around the perverse incentives to try and do the right thing. So how do we actually turn that upside down, the right way round rather, so that people are being paid to do what's required rather than not wanting you to do something that reduces costs and improves patient outcomes?
I think some of this morning is what made me think that in each area, in your ICB or in your trust, you've got to have that environmental champion. And somebody mentioned your your director of finance. If they're not on board, you've got a problem. And I think your only way of getting around that is going to be the patients. Because let's be honest, I hope I'm wrong, but in the next few years, if you went along and said, look, for environmental reasons, I want to do X, but it's going to cost the trust $500,000, you and I know we're not going anywhere. But actually, if you can get the patients, and then you can get public health, because somebody else made a comment about your public health staff should be driving what you're doing. If we can start there maybe, and that's in Northamptonshire, I don't know about where everybody else works, that's where I'm going to go back and try and start. Because I've done this project, it's fantastic, I love it, the patients love it, it's gone nowhere. So nobody that I'm aware of in Northamptonshire has replicated this yet. And we all know the reasons, because some of them are on payment by results, some of them are just clinicians like me, they're just too busy. So it's how we change that to get the environment first and the patients next to it, and then the finances.
Great, thank you. Can I please ask you to really join me in thanking our presenters for their time. Thank you.